I'll be taking a short session on inflammatory markers in COVID-19. Basically, uh, if you see the current situation of COVID, we have very few inpatients, or very few of them are admitted, and very few of them required hospitalization or maybe ICU treatment or oxygen support. So these inflammatory markers were used during the second wave, and even for the current situations, there are some infectious there are some inflammatory markers that are being used as a part of the assessment, or maybe can called as a pre-assessment of the condition of the COVID-19 positive or patient. So we will go through these markers as a part how they are useful in the evaluation of the COVID-19 cases. So basically, as of all of us knows, the clinical presentation of the COVID-19 varies from mild to critically ill patient. And now if you see currently the situation, most of them have mild influenza-like symptoms or maybe asymptomatic. And very few patients are progressing towards severe pneumonia, acute respiratory distress syndrome, or multiple organ failure. Now, if you see the current situation, there are very few, or there are limited cases which are going to such conditions. But during the second wave, we have seen some cases have gone to the level of respiratory distress syndrome and multiple organ failure, and there were many deaths also. So basically, this is the clinical presentations what we have seen till now during the COVID, right from the first wave, second wave, and third wave. And the next part is, as soon as this patient progresses to severity or critical stage, the risk of poor outcome increases significantly. So we have seen those cases who that cases do not progress to the or that cases which do not require hospitalization or oxygen support. So as the cases goes, as the seriousness or as the criticality of the case increases, the outcome also varies significantly, or the final outcome, there are more chances of poor outcome in these cases. So it is estimated that around 10 to 15% of mild COVID-19 patients advance to severe cases, and maybe some becomes critical, and there are they may require treatment in the intensive care unit. So this severity or criticality of COVID-19 is strongly linked with the mortality. The high mortality rate among these cases are linked with immune system and resulting into cytokine storm. So now I'll just go through what is this cytokine storm, basically, because this is the basic pathogenesis, or this is what the basic mechanism behind the clinical presentation, or behind the severe clinical presentation of some of the COVID-19 cases. So severe or critical COVID-19 is strongly linked with mortality, as we have seen. The inflammatory markers have prognostic significance in patient with COVID-19, with higher level being associated with worse outcomes. So this worse outcomes, as we have seen, as direct relation with the inflammatory markers, and these inflammatory markers has come from these cytokine storms. So what is basically how these cytokine storms get produced during the COVID-19 infection? This we will see here. Cytokine release syndrome is characterized by extensive tissue damage and end organ dysfunction due to ineffective control of inflammatory cytokines released due to immune dysregulation. So basically, this was the pathogenesis behind the how these COVID-19 cases, or how this cytokine storm works, and this leads to sudden increase of or release of inflammatory markers, which is called as a cytokine storm. These cytokine storms manifest clinically with rapid clinical deterioration. So once the cytokine storm starts, or once the inflammatory markers start releasing in the huge quantity in the body, they are characterized by coagulopathy, hypotension, and multiple organ dysfunctions. So here in this presentation, we will see about some of the inflammatory markers, as well as at the end we will see also some of the markers of coagulopathy. So first of all, we'll see what is the role of this biomarkers in COVID-19, or why this testing of these biomarkers should be done, or why it is done to assess the progress of the diseases. So biomarkers in COVID-19 can be useful in the following areas. Now, first of all, is the early suspicious of disease. So once the case is detected as positive, so you need to see you need to have strong suspicion to see whether this patient is going to be under cytokine storm or rapid release of inflammatory markers. Next is confirmation and classification of disease severity. So what will be the severity of the disease? For that purpose, we need to test these biomarkers. Next is the framing of hospital admission criteria. Now, depending upon the levels of this inflammatory markers, we need to classify the patient for the hospital admission as well as for ICU admission. Then these markers can also be useful for rationalizing the therapies, assessing the response to the therapies. So you can monitor the response of the treatment with the help of these inflammatory markers. It is also useful for predicting the outcome or to assess the outcome of the patient. And finally, the framing criteria or for discharge from the ICU as well as the hospital. So depending on the levels of these biomarkers, they will be classified first into the severity. Then these criteria will be used for the admission to the hospital. These criteria will also be used for the admission to the ICU patient. Then it will be used for the determining the rationalizing the therapies, appropriate therapies, and the monitor the response of the therapies to predict the outcome. And finally, at what levels or at what stage the patient or the patients can be discharged from the ICU or can be shifted from the ICU to the home care or the routine isolation wards. So this is the basic use of biomarkers. So as we have seen, they have prognostic significance in patient, and higher levels are always or most of the times are associated with worse outcomes. As a routine markers of inflammation, so whenever a patient was coming to hospital, the first line of investigations which were done were the blood cell count, liver function test, renal function test, and quantitative assessment of LDH, serum ferritin, procalcitonin, CRP, interleukin 6, FDP, D-dimer. So at the end, FDP and D-dimer were used as a marker of to see the progress of coagulopathies or to predict the progression to the coagulopathies. So basically, the markers of inflammations from every part of or from each areas were classified like hematological markers, which include leukocytosis, lymphopenia, neutrophilia, depletion of CD4. Anyways, depletion of CD4 and CD8 counts. These were not monitored routinely, but maybe for some research purpose, it was done in some patients. But the routinely were done were lymphocyte count, neutrophil count, neutrophil to lymphocyte ratios, thrombocyte counts. So these were done as a marker of inflammation, cytokine, interleukin 6, C-reactive proteins, procalcitonin, lactate dehydrogenase. They were the markers which were routinely used as a inflammatory markers. Then coagulation markers are D-dimers, fibrinogen, fibrin degradation product, prothrombin time, activated prothrombin time. So these were also used for the monitoring coagulopathies. And there were some cases where even the cardiac markers were used as a inflammatory markers. Markers related to the liver function test like AST, ALT, bilirubin, albumins were used. Markers for muscles injury, creatine kinase, myoglobins were used. Renal functions, serum creatine markers, and electrolytes were used as an inflammatory marker or the biomarker for the progression of the COVID-19 cases. So we will see or we'll go through these markers one by one. So first of all is the ESR. As all of us know, it is a non-specific marker and primarily reflecting the changes in the plasma protein types. Higher ESR levels were associated with severity of COVID-19 cases. Severe COVID-19 cases are associated with prominent elevation of ESR as compared to the non-severe cases. So this increased ESR levels in COVID-19 cases reflects a more profound inflammatory response and expression of acute phase protein. So ESR was used as an acute phase protein as a marker of inflammation. The next is serum ferritin. Higher serum ferritin values prior to the terminal event were more significantly associated with death as a final outcome. Higher serum ferritin levels at the time of admission have been independently associated with severe death. So not only during the admission, but even the cases which have high serum ferritin values at the admissions, they were also directly related with the severe outcomes or with the critical outcome. Hyperferritinemia was also associated with independent risk factor as acute respiratory distress syndrome. Some report cases of hyperferritinemia are associated with more severe cases and more severe prognosis. High serum ferritin values were particularly prior to the terminal event have been significantly associated with adverse final outcome. The next is C-reactive protein. Again, higher CRP levels prior to the terminal event are more significantly associated with an adverse final outcome. CRP levels at the time of admissions and prior to discharge or death are markers of poor prognosis. Higher CRP values during the initial stage of the disease are associated with greater CV severity scores and extensive lung involvement. Higher CRP values have been positively correlated with increased mortality in COVID-19 patient, and which is found in many cases, or many studies has also reported high C-reactive protein values where there was increased mortality. IL-6, it is also one of the inflammatory markers which was extensively used during the second wave of the COVID, as many of the people who are working in the laboratory, they might be seeing before this COVID second wave, what number of investigations we were doing for COVID interleukin 6 was negligible, or maybe we were doing hardly 4 to 5 tests per month. But during this COVID-19 second wave, most of the cases were tested for interleukin 6. Interleukin 6 was also used as a marker of progression. It was used as a marker of severity and even as a criteria for discharge of this patient from hospital. And the highest levels of COVID-19 interleukin 6 are found among the survivors as compared to non-survivors as compared to survivors. The next marker is the procalcitonin, as higher procalcitonin levels are also associated with worse prognosis. Elevated procalcitonin levels are associated with increased mortality. The next marker, which is used as a neutrophil to lymphocyte ratio, and it is the most established marker that reflects systemic inflammatory response and is easily obtainable through blood count. So it was very easy to test the neutrophil to lymphocyte ratio, because basically it is done as a routine test. So it was much easier to test the neutrophil to lymphocyte ratio as a marker of severity. Elevated NLR ratio was associated with severity and mortality in COVID-19 cases. The next is the lactate dehydrogenase. Again, it was the high values were associated with worse overall outcome of the patient. In addition to lactate dehydrogenase, lactic acidosis may also contribute to the higher mortality in patient with severe COVID-19. ESR marker we have already seen as a marker of inflammation. So at the end, I have also included the coagulopathy marker, because a higher incidence of DIC was described in patients, even in survivors, as well as the patient could not be survived in the COVID-19, and has a common features with both DIC and sepsis induced. So markers which were done during the coagulopathy markers are thrombocytopenia, that mild thrombocytopenia was evidence in many cases, mildly prolonged prothrombin time, increase in fibrinogen, and raised D-dimer values were seen in the patients, and these markers were used as a marker of patients who are progressing to the coagulopathy. So in this table, we have given a short account of all the markers, including the inflammatory markers and coagulopathy markers. Regarding the values, as we can see, the D-dimer values were significantly higher, fibrinogen values were higher, platelet values were lower, or even in the biological reference range. PT, PT, you can see there was a increase in prothrombin time. Even anti-prothrombin time was increased in some cases. Leukocyte was increased. There is a decrease in lymphocyte count, increase in neutrophil count, increased level of factor 18, increased level of Wolff-Riemann factor. Then regarding the inflammatory markers, increased level of CRP, procalcitonin, ferritin, and complement layers were seen as a inflammatory markers in COVID-19. So this table has given a short account of all the inflammatory markers as well as coagulopathy markers during the COVID-19 cases. So with this, I will conclude this short session for the inflammatory markers in COVID-19 cases.